Welcome to our channel Medicine A to Z. Today we are going to discuss about community-acquired pneumonia. Definition: community-acquired pneumonia refers to an acute infection of the pulmonary parenchyma acquired outside of the hospital. Hospital-acquired and ventilator-associated pneumonia. Hospital-acquired pneumonia refers to pneumonia acquired more than 48 hours after hospital admission. Ventilator-associated pneumonia refers to pneumonia acquired more than 48 hours after endotracheal intubation. Nosocomial pneumonia refers to an acute infection of the pulmonary parenchyma acquired in hospital settings and encompasses both hospital-acquired pneumonia and ventilator-associated pneumonia. Epidemiology: approximately 650 adults are hospitalized with CAP every year per 100,000 population in the United States. Risk factors. 1. Age. One significant risk factor is age. Individuals who are older, particularly those over the age of 65, are 3 times more likely to develop pneumonia compared to the general population. Number 2. Comorbidities. Chronic comorbidities also play a role. Conditions such as chronic obstructive pulmonary disease, COPD, bronchiectasis, asthma, congestive heart failure, stroke, diabetes mellitus, malnutrition, and immunocompromising conditions increase susceptibility to pneumonia. Number 3. Viral infections. Viral respiratory tract infections, particularly influenza, can weaken the immune system and pave the way for pneumonia. Number 4. Impaired airway protection. Impaired airway protection is another risk factor. Conditions that increase the risk of inhaling stomach contents or upper airway secretions, especially in cases of altered consciousness due to stroke, seizure, anesthesia, or substance use, can predispose individuals to community-acquired pneumonia. Number 5. Smoking and alcohol overuse. Lifestyle choices also matter. Smoking and excessive alcohol consumption can weaken the immune system and damage the respiratory tract, making individuals more susceptible to pneumonia. Number 6. Residence in low-income settings. Furthermore, residents in low-income settings, where access to healthcare and sanitation may be limited, can increase the risk of exposure to infectious agents. Microbiology. Streptococcus pneumoniae and respiratory viruses are the most frequently detected pathogens in patients with CAP. When it comes to community-acquired pneumonia, several bacterial culprits can be at play. The most common troublemaker is good old Streptococcus pneumonia, causing the majority of cases. But it doesn't stop there. Haemophilus influenzae and Moraxella catarrhalis also like to join the party. Watch out for Staphylococcus aureus and Group A Streptococci too, as they can be behind those pesky pneumonia symptoms. And let's not forget about the aerobic gram-negative bacteria, like Klebsiella spp or Escherichia coli. They're not shy about causing trouble either. But wait, there's more. Microaerophilic bacteria and anaerobes, often associated with aspiration, can also sneak in and wreak havoc on the lungs. Now let's talk about the atypical bacteria, the rebels of the microbial world. They don't play by the rules, showing intrinsic resistance to beta-lactams and giving gram stains and traditional culture techniques the cold shoulder. First up, we have Legionella spp, lurking in water sources and causing trouble. Then there's Mycoplasma pneumonia, the sneaky culprit behind a good chunk of atypical pneumonia cases. Don't underestimate Chlamydia pneumonia and Chlamydia psittaci either. They can stir up trouble in the respiratory tract. Last but not least, Coxiella burnettii, the agent responsible for Q fever, is also on the list of atypical troublemakers. When it comes to community-acquired pneumonia, viruses are also major players in the game. First off, we've got the notorious influenza A and B viruses, making seasonal appearances and spreading like wildfire. And of course, we can't forget about their infamous cousin, SARS-CoV-2, the virus responsible for the COVID-19 pandemic that shook the world. But wait, there's more. Other coronaviruses can also contribute to pneumonia cases. Then there's the familiar rhinoviruses, parainfluenza viruses, adenoviruses, respiratory syncytial virus, human metapneumovirus, and human bocaviruses, each with their own knack for causing respiratory distress. Important trends. Streptococcus pneumonia cases decreasing due to vaccination efforts. Increased recognition of various respiratory viruses. Despite thorough molecular and microbiological evaluations, only 50% of CAP cases reveal identifiable pathogens. Antimicrobial resistance. When it comes to Streptococcus pneumonia, not all regions are created equal. Macrolide resistance rates vary, often trending high in different areas around the globe. As for doxycycline resistance, it's a bit of a mystery with uncertain global estimates and significant variability. But here's the good news. Beta-lactam resistance, while varying by region, usually doesn't reach the heights of macrolides and doxycycline. And in the United States, fluoroquinolone resistance remains reassuringly low, typically staying below 2%. Methicillin-resistant Staphylococcus aureus. Methicillin-resistant Staphylococcus aureus, MRSA, is rarely responsible for community-acquired pneumonia. However, CAP linked to community-acquired MRSA can be severe, characterized by necrotizing or cavitary pneumonia. Complications of community-acquired MRSA-associated CAP include empyema, significant hemoptysis, septic shock, and respiratory failure. Pneumonia can present with a variety of symptoms. Common symptoms of pneumonia include cough, fever, chills, fatigue, malaise, and loss of appetite. Patients may experience sudden onset of these symptoms, often feeling unwell and run down. In severe cases, pneumonia can lead to sepsis, a life-threatening condition characterized by hypotension, altered mental status, and organ dysfunction such as kidney, liver, or low platelet count issues. Respiratory signs are also prevalent. Patients may exhibit tachypnea, increased work of breathing, and abnormal breath sounds like crackles and raunchy when a stethoscope is placed on the chest. Diagnosis. For most patients with suspected CAP, we obtain posterior-anterior and lateral chest radiographs. For selected patients in whom CAP is suspected based on clinical features, despite a negative chest radiograph, we obtain computed tomography, CT, of the chest, defining severity and site of care. The most commonly used severity scores are the Pneumonia Severity Index, PSI, and CURB-65. Ambulatory care. CURB-65 score of 0-1 indicates low severity, suitable for outpatient management. Hospital admission. CURB-65 score of 2 suggests moderate severity, recommending hospitalization for further observation and treatment. Intensive care unit, ICU, admission. CURB-65 score of 3 or 5 signifies high severity, necessitating intensive care management. Respiratory failure requiring mechanical ventilation. CURB-65 score of 4 to 5 may lead to respiratory failure, potentially requiring mechanical ventilation. Sepsis requiring vasopressor support. CURB-65 score of 4 to 5 indicates severe pneumonia with a risk of sepsis, potentially requiring vasopressor support in critical care settings. The presence of 3 of these criteria warrants ICU admission. Altered mental status, hypotension requiring fluid support, temperature below 36 degrees Celsius, respiratory rate of 30 breaths per minute or higher, arterial oxygen tension to fraction of inspired oxygen ratio of 250 or less, blood urea nitrogen level of 20 mg per deciliter or higher, leukocyte count below 4,000 cells, microliter, platelet count below 100,000 microliter, presence of multilobar infiltrates. Investigations. Outpatients. Generally, microbiologic testing not needed for mild CAP in ambulatory settings. Exception. Testing for SARS-CoV-2 during the pandemic. When it comes to patients with moderate community-acquired pneumonia admitted to the general medicine ward, there's a checklist of tests to ensure thorough assessment and targeted treatment. First up, we have blood cultures, helping to identify any bacterial pathogens circulating in the bloodstream. Then, a sputum gram stain and culture can provide valuable information on the specific bacteria causing the infection. But wait, there's more. We don't want to miss out on Streptococcus pneumonia, so urinary antigen testing is crucial. And since Legionella SPP can also rear its head, we opt for PCR testing whenever possible, with urinary antigen as a backup. In the era of COVID-19, SARS-CoV-2 testing is a must to rule out or confirm infection. And let's not forget about other respiratory viruses, especially during their peak season. Additional respiratory virus testing ensures we cover all bases, leaving no viral stone unturned. Patients with severe CAP, including ICU admission, these additional tests are conducted. Bronchoscopic specimens for microbiologic testing when feasible. Types of tests vary, including aerobic culture, Legionella culture, fungal stain and culture, and respiratory virus testing. When it comes to treating community-acquired pneumonia in the outpatient setting, we've got a strategy that aims to hit the bullseye with our antibiotics. Our empiric regimens target the most common culprit, Streptococcus pneumonia, along with those sneaky atypical pathogens that can cause trouble. But wait, there's more. For outpatients with certain risk factors like underlying health conditions, smoking, or recent antibiotic use, we expand our antibiotic coverage to ensure we're covering all our bases. For those under 65, healthy, and without recent antibiotic use, we start with oral amoxicillin paired with a macrolide or doxycycline to target those pesky bugs. But for patients with major health issues, smokers, or recent antibiotic use, we kick it up a notch with oral amoxicillin clavulinate, along with a macrolide or doxycycline for broader coverage. If beta-lactams aren't an option, we've got alternatives in our arsenal. Think third-generation cephalosporins paired with a macrolide or doxycycline. And for patients unable to tolerate beta-lactams altogether, respiratory fluoroquinolones or lefamulin step in to save the day. Summary: amoxicillin or oral amoxicillin, clavulinate or third-generation cephalosporin plus macrolide or doxycycline. Patients unable to use beta-lactams, respiratory fluoroquinolone like levofloxacin, moxifloxacin, gemifloxacin, or lefamulin. Inpatient antibiotic therapy summary: empiric regimens designed to treat Staphylococcus aureus, gram-negative enteric bacilli like Klebsiella pneumonia, in addition to typical pathogens such as Streptococcus pneumonia, Haemophilus influenzae, and Moraxella catarrhalis, and atypical pathogens like Legionella pneumophilia, Mycobacterium pneumoniae, and Chlamydia pneumonia. Initiate therapy within 4 hours of presentation to reduce mortality risk. Key factors in regimen selection: consider risk of Pseudomonas and/or Methicillin-resistant Staphylococcus aureus, MRSA infection. Risk factors include colonization, prior infection, recent hospitalization with IV antibiotics, and local prevalence. Regimens for patients without suspicion for MRSA or Pseudomonas. Combination therapy: beta-lactam plus macrolide or monotherapy with respiratory fluoroquinolone. For patients unable to use macrolide or fluoroquinolone, beta-lactam plus doxycycline. Regimens for patients with suspected pseudomonal infection. Combination therapy: antipseudomonal beta-lactam plus antipseudomonal fluoroquinolone. Antipseudomonal and antipneumococcal beta-lactams are imipenem, meropenem, ceftazidime cefepime, and piperacillin tazobactam. Selection informed by susceptibility pattern for prior isolates. Regimens for patients with suspected MRSA infection. Add agent with anti-MRSA activity, like vancomycin or linezolid, to above regimens. Prefer linezolid over vancomycin for community-acquired MRSA. ICU admission antibiotic therapy. Similar approach to general medical ward. Initiate antibiotic therapy within 1 hour for critically ill patients. Do not use monotherapy due to severity of illness. Patients without suspicion for MRSA or Pseudomonas initial regimens: beta-lactam plus macrolide or beta-lactam plus respiratory fluoroquinolone. For penicillin hypersensitivity or inability to use beta-lactams, combination therapy with fluoroquinolone and aztreonam. Regimens for patients with suspected MRSA or Pseudomonas. Add agent with anti-MRSA activity like vancomycin or linezolid, or anti-pseudomonal therapy to above regimens. Adjunctive glucocorticoids. Consider for patients with impending respiratory failure or requiring mechanical ventilation. Continuous infusion of hydrocortisone 200 mg daily for 4 to 7 days followed by taper. Avoid in patients with CAP caused by influenza, tuberculosis, fungal pathogens, acute viral hepatitis, or active herpes viral infection. Administer when indicated for refractory septic shock, COPD exacerbations, or COVID-19, following respective guidelines. Duration of therapy. Determining duration. Based on patient's clinical response to therapy. Treat until patient is afebrile and clinically stable for at least 48 hours. Minimum of 5 days of therapy. Duration varies. Mild infection, 5 to 7 days. Severe infection or chronic comorbidities, 7 to 10 days. Extended courses for immunocompromised patients, certain pathogens or complications. Procalcitonin-guided antibiotic discontinuation. Not used to determine initiation of antibiotics. Used as adjunct to clinical judgment for discontinuation in clinically stable patients. Obtain level at diagnosis and repeat every 1 to 2 days in stable patients. Discontinue antibiotics based on clinical improvement and serial procalcitonin levels. Follow-up imaging. Immunocompetent adults recovered from CAP. Most patients with clinical resolution after treatment do not require follow-up chest radiograph. Radiographic response lags behind clinical response. Follow-up clinic visits used to assess risk for lung cancer based on age, smoking history, and recent imaging findings. Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.